Okay, so I'm David Barad. I am from New York. I work at the Center for Human Reproduction with Dr. Norbert Gleicher, and I'm grateful for the invitation to come here from Ricardo Ash, an old friend of mine, and I'm very pleased to be with you. These are my disclosures, and the original PGTA hypothesis was formulated by Yuri Valinsky, who was one of the originators of pre-implantation genetic testing in Chicago. And he said that the elimination of aneuploid embryos from a cycle cohort prior to transfer will increase implantation pregnancy and live birth rates of the remaining embryos. Now, it's not quite correct because nothing will increase the actual embryos that remain. They have a potential to be good or to be bad. By eliminating, you may increase the chances of pregnancy, live birth rates in the current transfer. And at the time that Dr. Valinsky formulated this hypothesis, we were much younger. We didn't have cryopreservation, and it was very important to pick the right embryo in the first transfer because you couldn't save the remaining embryos. That's not necessarily true today. So what are the promised objectives of PGTA? It will detect chromosomal abnormalities, improve embryo selection, reduce miscarriages, shorten the time to pregnancy, that there'll be fewer embryo transfers, and that will facilitate single embryo transfer. And some of these things are true to an extent, but let's explore what this means. In much of the literature that people use to promote the PGTA at their places, all of these things are promoted. We all know how PGTA works now with NGS. It's very specific. It's probably true that an embryo that is identified as being euploid is most likely euploid and most likely has a high chance of implantation. So improved implantation rates per transfer, that's true. However, not necessarily per cycle and not necessarily per patient. The ASRM recently published a paper looking at the use of PGTA testing for aneuploidy and released a committee opinion. In it, they reviewed several randomized controlled trials, and we'd like to talk a little bit about those now. This first is, well, get back there. This first is by Yang, and it talked about ongoing pregnancy, higher in the PGTA group, but notice they were randomized on day 5 blasts. This next is from Foreman. Foreman and Scott published several papers. In this first one that they published, they found, I can hardly read my thing here. They published that it reduced multiple pregnancies, and there was no difference in miscarriage. And of course, it had ongoing pregnancy rate of PGTA for about 60% versus 65% for the control. So it actually didn't increase in that study. In this last one by Scott, they showed, sorry, it's going too fast. They showed that, again, they're randomized at day 5 blast. All these are randomized at day 5 blast when they do the PGTA. Interesting, in this one, they transferred 2 euploid blasts and 2 control blasts. And of course, there was a much higher rate of twinning in the PGTA group compared to the other. Miscarriage rates were lower. We're going to talk a little bit more about the STAR study, but to begin with here, to say that in the STAR study, they randomized patients who had at least two blastocysts, and there was no difference in the intention to treat group, meaning among all the people who were randomized between the control and the study group. However, when they did a group, they found that among older patients, there was some advantage to the PGTA group. We'll talk about that a little bit more later. But when they looked at it on an intention to treat basis, which I'll explain in a minute, there was no difference. And lastly, there was this study by Yan, which was a true randomized study in China, in which they looked at cumulative pregnancy rates up to 3 transfers. And in that, they found that there was a disadvantage of PGTA for live birth in looking at cumulative pregnancy rates compared to the control. There were fewer miscarriages in the PGTA group, but that didn't offset the disadvantage in terms of cumulative live birth. This is Yan's study, and you can see that in the control conventional IVF group, cumulative pregnancy rates were about 81%. In the PGTA group, there were 77%. Neither is terrible. We would all appreciate having these high pregnancy rates, but the fact is the control group did better. So when do couples decide to use PGTA? Do they decide on the day that they have blastocysts or not? And the fact is that couples are advised that they need to make a decision to have PGTA before they start their cycle. They have to commit to doing PGTA. So the decision for PGTA is at the beginning of the cycle. In the SART statistics, which SART is the organization in the United States that records all our statistics in IVF, PGTA is not recorded until the day of the transfer. So when you look at retrospective studies or looking at SART, PGTA, again, those are based on at blastocyst transfer. Over here, not over here. So if you look at each of the studies we talked about before, all of the patients were randomized when they already had blastocysts. So you can't generalize a group that has blastocysts to a group that's making a decision before they start the study. So you can't advise all of your patients that they're going to have this high pregnancy rate when they're starting their cycle, because they may not ever have a blastocyst. So PGTA for embryo selection may be helpful when there are lots of embryos to choose from, but probably less helpful when there are few embryos. In my practice, the median age of patients that we're caring for is now around 44. So we take care of patients that are quite old in reproductive sense, and most of them have failed cycles at 4 or 5 other centers before coming to us. This is a graph that shows the chance of having a blastocyst at various ages. You can see the ages are increasing here. This is 41 to 42. This is 42, 44, 43, 44, and up. And you can see that here at 41 to 42, the chance of having a blastocyst is around 25%. As Scott's group showed, as you get much above 37, 38, the chance of having a euploid blast decreases significantly. So, for example, if we look at a 41 to 42-year-old woman, of 1,000 41 to 42-year-old women considering having IVF, only 25% will have at least one blastocyst in their cycle. That would be about 250 out of the 1,000. If we look at those who are going to have a euploid blast, that would be about 25% of 20% of those. So it represents about 50 women out of the 1,000. If we say 50 to 70% of euploid blasts will result in a pregnancy, that would represent 25 to 35 women who will become pregnant out of the 1,000 that were counseled at the beginning. So based on an intention to treat, meaning from the time you start your cycle, only 25 to 35 women out of 1,000 who are 41 to 42 years old will have a live birth per cycle start. And that would be about 2.5 to 3.5% live birth rate. If we look at the start statistics for women who are having a single embryo transfer of a blastocyst without PGTA, it also comes to around 3%. So the potential of embryos of a woman to have a live birth at 41, 42 going through IVF with a single embryo transfer will be about 3.2%. In contrast, if one did a multiple embryo transfer of a cleavage stage embryo, the chances would be around 10%. So for a 41 to 42-year-old woman, a single PGTA blast transfer would be 25 to 35 live births out of 1,000. For non-PGTA blast transfer, it would be about 32 live births out of 1,000 based on what we saw in the start statistics. If we did multiple cleavage stage transfer, that's 2 or 3 cleavage stage embryos, there'd be 106 live births out of 1,000, but there would be some twins and multiple pregnancies. They report about a 7.5% multiple pregnancy among the live births, which would translate to less than 1% out of the 1,000 patients that were treated. So retrospective studies often show improved pregnancy rates for advanced maternal age patients. However, only good prognosis patients are able to have a biopsy and would be included in the PGTA group. So 75% of those never got to blast. This is the randomized study by Munya and his group, the so-called STAR study we talked about briefly before. And you recall that PGTA did not improve overall pregnancy outcomes when they looked at all the women analyzed per intention to treat. That there was a significant increase in ongoing pregnancy rate per embryo transfer with the use of PGTA in the subgroup of women age 35 to 40 years. So that's their study cut off at 40 years. But this was not significant when analyzed by intention to treat. Let's look at that a little more closely. The women in the study were 25 to 40 years old. Enrollment was completed before oocyte retrieval, so everybody was enrolled before the retrieval. But randomization was only included for women who had 2 blastocysts. So this, the intention to treat protocol was among people who had 2 blastocysts. They were stratified in their analysis, and it's the oldest group that we're focusing on at the moment, the 38 to 40-year-olds. Women were excluded from the study if they had diminished ovarian reserve. And in the control group, the most morphologically favorable blast was frozen and transferred, and these were all single embryo transfers. The remainder were biopsied and frozen for future use. So it wasn't a cumulative birth rate. The PGTA arm was a selection based on euploid status and morphology, and the frozen embryo transfer was in the subsequent cycle for everybody. So here is their identification of how patients were selected. They were recruited back here, as being eligible, and they were randomized when they had 2 blasts. Now, the numbers that were analyzed, especially in this oldest group, are interesting. When they did their post hoc analysis, they looked at those that had been biopsied and had euploid blasts who had the transfer. So that was 122 in the PGTA group, 145 in the control group. Ongoing pregnancy 62 and 54, which was significantly different. However, 29 patients in the PGTA group had no euploid blasts or withdrew after randomization, and 6 in the control withdrew after randomization. So they were comparing these groups. The PGTA group at the time of randomization, even after randomization, they reduced it when they did their post hoc analysis. To be fair, you had to include all the people who were randomized. So when you did that in their so-called intention to treat analysis, there was no difference between the two, no significant difference between the two, when you looked at all 151 women in each group that had completed the study. Well, how about PGTA and ovarian reserve? We got data from SART. This is currently out for review and hopefully will be published soon, but I'm sharing it with you today. This is a retrospective cohort study of SART-CORE's database, and we looked at the ovarian reserve parameters for patients using autologous oocytes with or without PGTA. So we looked to see what the ovarian reserve is in the 2 different groups. Stimulation cycles were listed in the registry as yes for all or some embryos had PGTA, and those were classified as the PGTA cycles. Autologous cycles between 2021, so there were 20,000 or something people that we were looking at. And we excluded donor cycles, donor embryo cycles, and gestational cycles. The PGTA group were slightly older. They had a higher dose of FSH, had more oocytes retrieved, and had a history of more pregnancies, but were not more parous. Thus, they probably had a higher risk of miscarriage. This is a graph of AMH. These are the median AMHs and the 95% confidence limits for AMH as people get older. It's not coming. There we go. This upper bar is the median level for patients who had PGTA, and this lower bar is the median level for patients who did not have PGTA. And all because there are thousands in each of these groups, all these numbers are statistically significant. So you conclude that in general, even from the mid-30s on, patients with PGTA have higher ovarian reserve who do not. Looked at another way, these are the less than 35, 35 to 37, 38 to 40, and 40 years, and this is the percentage chance of having PGTA. You can see this is the highest AMH levels are here, and this is the lowest AMH level. You can see that patients with lower AMH levels are much less likely to have PGTA. So after 38 years old, PGTA with higher ovarian reserve and less likely to be formed in low ovarian reserve. Thus, one conclusion is that in retrospective studies, older patients with better ovarian reserve were more likely to use PGTA and thus more likely to achieve pregnancy. What about reduced risk of miscarriage? This is probably true. PGTA lowers miscarriage rates by excluding aneuploid embryos. There we go. But some studies do report lower miscarriage rates, but the absolute reduction is small, especially in younger patients that are less likely to miscarry anyway. Miscarriage is a multifactorial um, uh, issue. Euploid embryos can still miscarry due to non-chromosomal issues. We do uh, genetic analysis in all of our patients who have miscarriages, and genetics account for only about half of them. A lot of them are euploid. The benefit is not uniform across all age groups. In younger patients where the rate of antibody is already low, miscarriage rate is small. And false positives and embryonic mosaicism may result in discarding viable embryos that might not have miscarried. So lower risk of transferring embryos with chromosomal abnormalities, that's probably true. If you transfer a euploid blast, it's probably true. But what about those that are deselected? While PGTA detects common aneuploidies, it's not a diagnostic and cannot detect all genetic disorders, such as most cases balanced translocations and single gene defects. There can be false positive results due to mosaicism or biopsy sampling error, which can lead to discarding embryos that may have developed normally. And PGTA is not a replacement for prenatal testing. Almost all genetics laboratories recommend that patients have genetic testing, prenatal testing if they're older. Technology is evolving, but is still limited in its accuracy, especially in cases of low embryo numbers. I don't know if you saw this case report that was in Fertility and Sterility last year. It's a report of a chaotic embryo. There were a monogamous same-sex female couple. They produced only a single blastocyst in their IVF cycle, and the biopsy was this chaotic result. It was the only blastocyst they had, and they chose to transfer it against advice. And at the end, it produced a normal male child. The lab that did the genetic study was iGenomics. And around the same time, iGenomics went back and reviewed their chaotic embryo biopsies, and they reported that if a blastocyst is good and the chaotic embryo can be rebiopsied, we've observed a surprising 38% chance of a euploid result on retesting. This suggests that there can be some technical errors, perhaps, maybe in the way the biopsy is handled, even before it gets to the lab. But at the end of the day, this baby wouldn't be here if they hadn't chose to transfer it anyway. Fidelity is the degree of exactness with which something is copied or reproduced. How much is it true? If you reach into a bowl of beads and you pick up 4 white ones, does that mean that all the beads are white? And when we're doing a biopsy of an embryo, mosaic embryos can have several different types of genetic identities, and where you happen to do the biopsy can give you different sorts of results. So mosaicism is high. Rate is pretty high in embryos, and it's poorly defined across different labs. Just briefly, you can get mosaicism in many different ways, from trisomy rescue, from a mitotic error during cleavage, and et cetera, et cetera. So mosaicism is pretty common. This graph is showing the mosaic results across these various ages. And you can see that it's pretty constant, although the Aneuploid mosaicism starts increasing as people get older. There's still a degree of euploid, aneuploid mosaicism in all age groups. This is a study of implicit bias in diagnosing mosaicism. About 37,000 consecutive PGTA results, 17 centers, and they all had trophectoderm biopsy and with NGS. Just get through this quickly to the next slide. So a significant proportion of mosaic embryos are not used for IVF treatment, but there is a range in different labs from about 3.1 to 25% mosaicism, depending on the laboratory. So each lab has its own way of cutting off which they're going to call mosaic. Interestingly, the euploid diagnosis was highest for providers that were reporting low rates of mosaicism, meaning some embryos that would have been reported as mosaic in some labs were reported as euploid in that particular lab. So the definition of mosaicism that we use in IVF is based on just a few cells, whereas the actual correct diagnosis of mosaicism refer to the whole embryo, and we obviously can't sample the whole embryo. So some labs don't report mosaicism at all. Some will report it at 20 to 80%, some at 40 to 80, some at 50 to 80, low versus high level, and it is somewhat confusing. What happens when you transfer mosaic embryos? I'm going to get to the thing. So I'm going to get to the next slide. Here we go. So these are the mosaic embryos. You can see this is low segmental, high segmental, low 1 chromosome, low 2 chromosome. You can see that these percentage live birth rates, these percentage live birth rates end up being relatively high. Most of you are not as old as some of us are, but when we started IVF, we would have been very happy with a 20% pregnancy rate. And if the alternative is not having a child at all because the embryo is not used, it makes no sense not to transfer these embryos. So mosaicism can result in suboptimal embryo biopsies that could create false results. Technical background noise create artifacts, and some subjectivity depending on how you define mosaicism. So if PGTA doesn't improve outcomes, why is it not unethical? ASRM SART in their paper that we showed you before showed no demonstrated value for routine PGTA and possible harm in certain populations, but they didn't call for any restriction. So how do we define ethics? The 4 pillars of medical ethics are autonomy, beneficence, malfeasance, and justice. So autonomy, patients need to have a say in whether embryos are used or not. I don't know about here, but in many centers in the United States will refuse to transfer an embryo that's not completely euploid, no matter what the patient wants. Beneficence, a cause of action that's in the best interest of the patient. We are here for the patients. We want to help them achieve a live birth. If we don't transfer an embryo, that's the surest way of seeing that they don't have a live birth. Non-malfeasance, if we're taking away live birth, we're actually not benefiting them. We may be benefiting our centers by increasing our per transfer pregnancy rates, but we're not protecting the patients. and justice is obvious. So IVF patients are starting to recognize this, and there have been some suits. There was a suit in Australia recently, and recently a class action suit was brought in the United States against several genetics laboratories. This is just a news article showing that this patient ultimately had transferred an abnormal embryo and achieved pregnancy. Why does the hypothesis exist? Why do we continue to think PGTA is a good thing? Well, we keep blaming the technique. Fish wasn't good enough, so we moved on to other ways of doing PGTA, ultimately to NGS, which is very, very accurate on the embryo that on the biopsy that you receive. However, the biopsy may be biased, as we showed before. They're ever evolving excuses, and at this point, the burden of proof is left to the skeptics, not to the people who are promoting the PGTA. So the randomized controlled trials have showed no benefit. There is evidence of mosaicism and self-correction. There can be sampling error in the trophectoderm biopsy, and some meta-analysis have shown some harm. So it's been suggested, do we biopsy or the whole embryo, the sort of the fluid from the blastocyst fluid, that there can be errors in looking at segmental changes, and some chaos in reporting standards. High financial costs, embryos discarded unnecessarily, and possibly not ethical if there's no benefit. So PGTA should not be performed outside of experimental frameworks. Most chromosomal abnormal embryos could be transferred and can result in reasonable pregnancy rates. We're suggesting that we reassess our clinical policies, we improve patient education, and support high quality trials. And maybe we should look at what our organizations are promoting. At CHR, we began transferring allegedly chromosomal abnormal embryos since 2014. We reported the first healthy offspring from an abnormal embryo transfer in the world in 2015. Shortly afterward, Greco reported a series in the New England Journal. This is a paper that we reported in 2022, Human Reproduction, Outcomes of abnormal PGTA, embryos with abnormal PGTA biopsy, previously refused transfer. So all these embryos were orphans, were taken from other centers so they could be transferred. In this report, we looked at 69 patients and 444 embryos. 50 women ended up having 57 embryo transfers. They were around age 42, and these are the characteristics. You can see that the per cycle live birth rate was about 14%, and per transfer about 16%. So that is significant for our patients who had been refused previous transfer, and that's the emphasis that we placed when we responded to this letter. Since then, we've had more live births, and this is just a summary of what they were. The first set are truly mosaic. These are mosaic segmentals. These are just segmentals, and this was a true aneuploid, whole chromosome aneuploid that was not mosaic. And so you can see all these resulted in live birth. This one actually had retained its segmental location. And these are the babies. So factors influencing decision to transfer non-euploid embryos, advanced maternal age, few embryos available, previous repeated PGTA failures, and this is the issue of autonomy and choice and emotional and financial burdens. Suggested hierarchy, segmental aneuploidies have about a 40% chance of going on. Mosaic embryos, full chromosomal abnormalities are last in the list, and we generally don't transfer possibly viable trisomies like trisomy 21, and we don't transfer Swires or Turner syndrome X or XXY. So final thought, are we using PGTA because it works or because we want it to work? Thank you.
Thank you.
Just letting you know, we have a conference coming up in the fall. We left some flyers for it outside in New York. If you want to come to New York in December, it's a nice place to visit, and hope to see you. Questions?